We appreciate everyone joining us today. This is going to be a wonderful webinar. We've been looking forward to it. Our moderator for this webinar is Dr. Craig Shimasaki. Dr. Shimasaki is Dr. Shimasaki is the co-founder and CEO of Molecular Labs, a neuroimmunology precision medicine company focused on identifying the underlying roots of neurologic, psychiatric, and behavioral disorders triggered by an autoimmune response. Dr. Shimasaki started his career at Genentech and has been in the biotechnology industry for over 35 years. As a scientist, his work spans all stages of research and development, from bench to bedside. His research included epitope mapping for an HIV vaccine, genetic breast cancer risk prediction biomarkers, a rapid influenza diagnostic, and therapeutics for infectious diseases, neuropsychiatric disorders, and noise-induced hearing loss. As a business person, he co-founded multiple companies and led multiple products through the FDA approval process and is co-inventor on multiple patents. Dr. Shimasaki received his BS in biochemistry from the University of California at Davis, his PhD in molecular biology from the University of Tulsa, and his MBA from Northwestern University's Kellogg School of Business. He is an adjunct professor at the University of Oklahoma, Price School of Business, and teaches biotechnology entrepreneurship. His passion is to help translate scientific and medical discoveries into acutely needed products so that more patients can live healthier lives. Our presenter for today's webinar is Dr. Daniel A. Kinderlehrer, MD. He is a nationally recognized physician with expertise in the fields of nutrition, allergy, environmental medicine, Lyme disease, and the healing of mind, body, spirit as a unified whole. Dr. Kinderlehrer co-founded the New England Center for Holistic Medicine in Newbury, Massachusetts, and has taught extensively, including practitioner training courses at the Omega Institute, the National Institute of Behavioral Medicine, the American Academy of Environmental Medicine, and the International Lyme and Associated Diseases Society. He created and organized the Lyme Fundamentals course, which is presented annually at the International Lyme and Associated Diseases Society conferences. He is the author of several articles in medical journals, the Lyme Times, and Psychology Today. His integrated medical practice in Denver, Colorado, focuses on diagnosis and treatment of tick-borne illness. Dr. Kinderlehrer is the author of Recovery from Lyme, the Integrative Medicine Guide to the Diagnosis and Treatment of Tick-Borne Illness, which was released in March of 2021. So Dr. Shimasaki, I will turn this over to you, and thank you both very much for being with us today.
Thank you again for joining us. Appreciate your attendance, and we look forward to an exciting sharing of some information today. I'm going to just take a few minutes here to talk a little bit about the background of immune-mediated neuropsychiatric disorders. And as you can hopefully see my screen at the moment, I'm going to advance here. We know that there is a complex interaction now between various types of infections, the immune system, and the brain. And so whether it's autoimmune antibodies, inflammation, microglia, cytokines, mast cell activation, it is all, though, predisposed in the sense that their genetics is involved. So whether it's various types of SNPs, or what we might think of mutations or deletions, or even epigenetic information, there's a lot of information coming out on that. But we know that these things are connected. We see more and more research that ties in autoimmune diseases and psychiatric disorders, and also infections and their role in producing what we'll call anti-neuronal antibodies and various types of behavioral and psychiatric disorders. So one interesting journal article in JAMA Psychiatry, which talked about infections that were associated with an increased risk for neuropsychiatric illnesses in children, It was a Danish study that looked at over 1 million individuals from birth to age 18. And what they found was there is a direct correlation between an individual being hospitalized for a severe infection and the risk of developing various types of mental disorders, which increased by more than 80%. And that includes for the diagnosis of things such as schizophrenia, ASD or autism, obsessive compulsive disorders, ADD and ADHD, personality disorders, oppositional defiance, and tic disorders. And in an editorial, they spoke of how could infections or exposure to infections affect the brain mechanistically and give rise to mental disorders. Circulating autoantibodies that enter the brain via compromised blood-brain barrier and bind to neurotransmitter receptors is a potential explanation. And this mechanism has been proposed in pandas and other mental disorders. Although today we're not going to talk about pandas per se, but there is a very similar medical model that also includes pandas. And biologically, what we see is this is maybe a schematic of how that occurs. So we all get exposed to various microbial, viral, fungal infections during our lifetime. And our body is programmed to produce antibodies that recognize these infectious agents, and that's our normal process. In certain individuals, we'll briefly speak about molecular mimicry, the antibodies that they produce, which target specific portions against these infectious agents, actually mirror or mimic parts of our body. In this case, it's neurologic receptors. So the resulting situation that occurs is there is brain dysfunction, what we might think of as friendly fire in the wartime. And these antibodies then are capable of, and basically it's the immune system, of producing various types of neuropsychiatric symptoms. Traditionally, symptomatic treatment involve various types of antipsychotics, various types of medications that are typically addressed or addressing these symptoms. So the goal here is to look at what is the root of those symptoms. And we've seen this happen with COVID, or what now known as long COVID, where SARS-CoV-2 and the spike protein has sequence homology, and various types of antibodies are cross-reactive from cardiovascular targets, neurologic targets, and other targets in the body. So the challenge for you and patients with these various types of autoimmune neuropsychiatric disorders secondary to infection is to actually be thinking outside the box. And this is an important area, and Dr. Kinderlehrer is going to be talking about that here in just a moment. There tends to be certain infections that are more frequently associated with this type of manifestation, and you can see them here: group A strep, influenza, varicella, mycoplasma. In particular, Babesia and various types of species, and the species of Borrelia or Lyme, and Bartonella, Coxsackie virus. And so just sort of as an overview, the parts of streptococcal bacteria have various types of carbohydrates and proteins to camouflage it, and there are portions of them that mimic parts of the heart. And this is why we see in various cases of a strep-induced rheumatic fever. And then the neurologic manifestation of rheumatic fever is Sydenham chorea, and that's part of the basal ganglia in which these antibodies are directed against. But there are also similarities, some of the joints, and then impact on the kidney. So we also see that there's sequence homology between Borrelia burgdorferi and the M protein in strep, which why you may see very similar types of symptoms in patients that may be diagnosed with post-treatment Lyme disease. And so this article just describes the sequence homology between the outer protein, the surface protein A in Borrelia, and the M protein in strep pyogenes, which again is one of the molecular mimicries that identifies in these antibodies. So you can kind of think about this as friendly fire in the wartime, where our own troops are being indistinguished from the enemy troops. And this is typically because what we see happen is that it occurs in patients that may have some type of genetic factors in the major histocompatibility complex, the HLA class 1 and class 2, And therefore, in your clinical workup and maybe in the history, you may find a very high percentage of the time there is a family history of some type of autoimmune dysfunction in patients that may present with these various types of sudden onset or chronic neuropsychiatric disorders that don't respond to traditional medications. So the question, which we're not going to be talking about, is this limited to pandas and PANS, which was mentioned. PANDAS is referring to an autoimmune disorder that's sudden onset associated with strep, but there is another term that encompasses both of those, and that's PANS. But more importantly, it's really a biological condition in which we might think of basal ganglia encephalitis, autoimmune encephalitis, or autoimmune encephalopathy that's secondary to infection, because encephalitis is just the Greek term for inflammation of the brain, or the Greek term for encephalopathy is disorder or disease of the brain. So the overall goal of medicine and precision medicine in this case is to identify patients that are presenting with these various symptomatic presentations, neuropsychiatric and behavioral disorders, and identify those that are infection triggered or immune mediated, as to those that are genetic, neurologic, psychiatric that can be treated with traditional psychotropic medications. And then identifying the appropriate immunomodulatory treatment, anti-infective treatment, anti-inflammatory treatment, or anti-infective treatment for underlying infections, which is actually what we are doing here at Molecular Labs, developing artificial intelligence predictive algorithms to be able to identify and predict which treatments may work in the future for these patients. So in conclusion here, we want to at least present that autoimmune encephalopathy of infectious etiology can be one of the underlying roots for a whole host of different types of disorders. And it's something that should be considered in a workup of a patient, and that these anti-neuronal antibodies are potentially those that can help aid in the diagnosis and treatment. And so I am going to end there, and I'll let Dr. Kinderlehrer share his presentation.
That was great, Craig. I wish I had someone in my office who could make those beautiful slides. So today I'm going to be talking about exactly what Craig said. I'm going to be talking about neuropsych conditions associated with these microbes, and particularly tick-borne microbes. So I am about to share my screen, and then I go over here, and voila. Okay. So basically the point of this talk is, when someone presents to your office with some mental health complaint, most often it's anxiety, depression, but virtually any, we'll get to it. When should you think that maybe there's an underlying organic etiology that needs to be evaluated in treatment? So I usually don't go through these what's going to happen, what are you going to learn, but it's actually a good outline for what we're going to be talking about. What I want you to do is appreciate just how big this Lyme epidemic is, learn the neuropsychiatric manifestations, recognize when to suspect an underlying tick-borne infection in your patients who present with mental illness, and understand the pathophysiology, which Craig's really already done a good job of. I do not have any disclosures. So we're going to start off with, how big a problem is Lyme disease? Right now, the CDC reports 500,000 new cases of Lyme disease a year. And you need to understand that the CDC has a surveillance criteria, or what they call a case definition, surveillance and reporting criteria that allegedly is mandated by the state, that each state then turns over the numbers, but doctors don't do it very well. They have an algorithm to come up with these 500,000 new cases, but what you need to understand is that these surveillance criteria are very restrictive. There's one study that suggests it's actually only going to hit 1 in 40 people. The CDC makes it clear that, in fact, these surveillance criteria should not be used in the doctor's office. Nevertheless, That's exactly what most doctors do, and that's what insurance companies do when they're reviewing these charts. In fact, there's a study that shows that if you apply the CDC's two-tier laboratory test surveillance criteria, which is first you have to have a positive ELISA test, then you have to meet these very restrictive criteria on a Western blot, that you're going to miss between 1 in 4 and 1 in 5 patients. This is, think about that. Think about if you're doing a pregnancy test, right? But even the Lyme ELISA test, which is supposed to be a screening test, can have 50% or more false negatives. So, one needs to do a lot more investigation than that. But the point is that if 500,000 represents 1 in 4 or 1 in 5 cases, we're talking about 2 million new cases of Lyme disease annually in the United States. It's huge. It's huge. And it's not just in the Northeast. So it is now well accepted that at least 10 to 20% of these acute cases become chronically ill, and in some studies up to 50%. But let's take 10%. 10% of 2 million, you're talking about 200,000. So 200,000 plus people are developing chronic illness every year. These cases, which first were diagnosed as acute Lyme, were treated, but went on to have chronic symptoms. They are called post-treatment Lyme disease syndrome, PTLDS. This is a designation that doctors like myself abhor because it implies that there's something else going on. Well, there is something else going on, but the Lyme is still there. I can guarantee it. And there are co-infections, which we will be talking about. While the states most endemic are, New England, that's famous for sure, but it's really the states with the most moisture. So the Northeast, the Southeast, the Great Lakes, the Northwest. I live in Colorado, and that's there's a reason for that. It's not coincidental. And but I lived in Massachusetts. I and my 3 daughters and my ex-wife, we all got Lyme disease. Lyme disease is now reported in all 50 states. Okay, so if we're talking about chronic Lyme disease, and if you want to be politically correct, you might use the word persistent instead of chronic, but because somehow chronic Lyme disease has this bad name. Then there's 2 categories of people. One is the category we were just talking about, those with a prior history of acute Lyme disease. They had short-term antibiotics. Sometimes they're only treated for a week. Hopefully they're treated for at least 3 weeks, but they either continue to be symptomatic or have the recurrence of symptoms weeks or months after that. And these people, like I said, they're labeled with PTLDS. And then there's a whole other subset. I shouldn't say subset. There's a huge group. Those who, they never saw a tick bite. They never saw a rash. They never saw, maybe they had a viral syndrome. They didn't think much of it. But they were never aware, never were diagnosed with acute Lyme disease. And they subsequently developed chronic symptoms, okay? There's no way we know how many these people are, but in my clinical experience, they probably outnumber the PTLDS patients by 4 to 5 times. So if we're talking at least 200,000 people who have PTLDS every year, and that's a low number, multiply that by 4 or 5. This is an epidemic. I mean, this huge epidemic. Okay, and here's a tiny little sucker. I mean, you can see why it's so hard to find these guys. Especially, they like to hang out and attach in warm intertriginous areas like the armpit, the scalp, the groin, behind the knee, and so on. I can tell you in my patient population, I would say that less than 20% of people ever saw a tick attachment. Okay, so what are we talking about? When we're talking about chronic Lyme disease, we need to be clear. Virtually every one of them, every person who develops chronic persistent Lyme infection are additionally infected with other tick-borne microbes, and these are called co-infections. And here are the ones that are well established: Babesia, Bartonella, Mycoplasma, tick-borne relapsing fever, Anaplasma rickettsia species, and Powassan virus. And I can't tell you how big a problem this is. What I can share, though, is that I've been doing nothing but seeing patients with tick-borne illness for over 2 decades. In the past 25 years, my memory only goes back to maybe the last decade. I have not seen a patient with either acute Lyme, or most of my patients have chronic persistent Lyme, who do not have at least 1, often 2 or 3. And I'll just give you an example. I am now consulting on a dude who just got out of the hospital because he had Lyme meningitis, and he still has a cranial nerve palsy, and he's not feeling very well, and came to me for ongoing treatment. But he has besides the well-documented Lyme that they figured out in the hospital, he has Babesia, he has Mycoplasma, he has spotted fever group, which is a rickettsial infection. He has Mycoplasma, and I think he has Bartonella. Okay, that's what we're dealing with here. Other comorbidities. We're going to talk about this, but basically, because the immune system becomes so hyperreactive, there's so much inflammation, and there's disruption in nervous function and neuroendocrine function, these people develop problems with endocrinopathies. I would say the adrenals and the thyroid would be the most common, but pituitary would come close after that. They develop sensitivity syndromes to mold and foods. Before they got Lyme disease complex, I'm going to call it, before they got it, they did not have these sensitivities. They're living in a moldy house. Everyone is fine. They're not reacting to it. The person with Lyme gets really sick from it. Suddenly, these people develop food sensitivities. And I see a whole lot of people who develop problems with gluten. The more common foods that they develop sensitivities to would be dairy, eggs, corn, interestingly, and yeast. So another thing that happens is reactivation of dormant infections. We see this particularly with COVID, right? Oh my God, we're seeing so much reactivation of Epstein-Barr virus in people who've had COVID. They have long COVID. We also see it with COVID vaccine in some cases, but we can see it with Lyme, that any microbe that's been dormant can be activated because of the disruption in normal immune function. So I like to call these patients, my preferred nomenclature is Lyme disease complex. It's in all of the above. Yes, they have Lyme, but they also have these other infections. They develop hypersensitivity syndromes and endocrinopathies, and often activation of otherwise dormant microbes. I mean, it's big, it's complex. Okay, this is a bit about co-infections. So they increase the severity and symptoms and make treatment more difficult. Huge. I mean, I just can't tell you how big a difference it is between just plain Lyme and treating someone with Lyme, Babesia, and Bartonella, which most of my patients have. Okay, it's not if 4 weeks, 3 to 4 weeks of antibiotics got rid of Lyme, which is not clear, by the way. It's never been shown that 3 to 4 weeks of an antibiotic will eradicate Borrelia burgdorferi. But if to the extent that perhaps it works, it will not work if there's a co-infection present. Co-infections generally cause more severe neuropsychiatric issues than Lyme disease. One of the problems with Lyme, one of the many problems with Lyme, is that when you read about clinical manifestations of Lyme disease, it really does not it does not identify subsets of what might actually be caused by the co-infections. And there's reasons for that. It's a big deal. And these 2 co-infections, Babesia and Bartonella, the tests for them are not very good. They're getting better in specialty labs. I'll talk about Babesia first. It's a very common Lyme co-infection is not a bacteria. It's a protozoa in the same general family as malaria. It can cause all the inflammatory conditions that we associate with Lyme, the fatigue and the headaches and the joint pains and the muscle aches and cognitive complaints. But the symptoms that particularly suggest Babesia infection include a lot of really bad headaches and migraines, night sweats, chills, and temperature intolerance, like in the winter. I had this actually. I can tell you exactly what it was like. In the winter in Massachusetts, I could not get warm. And as soon as it hit high 80s into 90 degrees, I could not get cool. Severe temperature intolerance, very narrow range. Air hunger or some form of dyspnea where people just feel like they're not getting enough oxygen. I've had people, and this often is associated with some chest pain for reasons I don't know. It's often in the left side on the ribs. I see this, and it can be severe chest pressure. And I've had people go to the emergency room, and then they end up, getting the full evaluation. They get a chest X-ray, they get an EKG, they get the troponin levels, et cetera, et cetera. It's all, and their oxygen saturations are perfectly normal, and yet they feel like they're not getting enough oxygen. Babesia does that. It can cause nerve pain, different forms of neuropathy, and dysautonomia. We can see dysautonomia with all these functions. Again, it's the inflammation tends to also hit the autonomic nervous system, but when there's a lot of dysautonomia, we're seeing POTS and neurally mediated hypotension, but also anxiety syndromes and this temperature dysregulation and so on. The worst dysautonomia is associated with Babesia. Bartonella, I can tell you, Lyme doctors will tell you, Bartonella is the worst. It causes the most inflammation, and it causes the worst in neuropsychiatric symptoms. And it can cause the worst neuropathic pain. When I see patients with mental health disorders that are really, really bad, and they have a tick-borne infection, I'm always looking for Bartonella, and it's virtually always there. The skin reactions to Bartonella include stria, which are often mistaken for stretch marks, and I'm going to come back to that. Okay, 4 central points. Lyme disease complex often presents as a psychiatric illness or some major mood disorder, accompanied by some physical symptoms. Pattern recognition is essential in diagnosis. Testing for Lyme is not straightforward. The diagnosis is still not generally accepted by mainstream medicine despite overwhelming evidence. Go figure. The IDSA, the Infectious Disease Society of America, cites 4 retreatment studies as proof that chronic Lyme doesn't actually exist. Well, I go into this in a lot of detail in my book, but this is what it comes down to. All 4 studies significantly flawed in design, execution, or interpretation. Some of those studies, in fact, showed benefit of retreatment, and somehow that wasn't significant. But here you can see some of the issues: small sample size, selection bias, subtherapeutic dosing, and short lengths of treatment, and failure to acknowledge benefits of retreatment. Like I said, I go through this, study by study in my book. And then proof that chronic Lyme and co-infections do exist. There you go. There's a whole lot of articles out there. Bad news is you have Lyme. Good news is I don't believe in that. So you're fine. This is a joke, but I'm telling you, this happens. I'm in Colorado, but it happens all around the country. Why do these bugs persist? Why doesn't the course of antibiotics take care of them? And all I can tell you is these are very, very smart bugs. If we had a war with the bugs, they would win. And here's some of the ways that they persist. They actually suppress our immune system. They can be sequestered in antibiotic privileged site, think tendons and ligaments and things like that. Persister bacteria, some of these bacteria simply don't respond to antibiotics, biofilms. It's now generally accepted that almost all chronic infections exist within these biofilm communities, and where they are protected from both our immune system and from the antimicrobials. Borrelia burgdorferi can morph into these atypical cystic forms where the other regular antibiotics simply don't hit it. They have these very long replication cycles, and as you know, antibiotics tend to hit these bugs when they're replicating. And then there's the co-infections, which I've highlighted because the co-infections are a huge deal. They simply make diagnosis and treatment and illness much worse. Okay, so I'm going to basically summarize what are we talking about with Lyme disease complex. Infection with Borrelia burgdorferi, the pathogen responsible for Lyme. And then the presence of co-infections. There will always be co-infections. And here they are, Babesia, Bartonella. I won't read it again, but I want to just point out that those two in particular result in more serious illness and more neuropsychiatric issues. And they are really challenging to treat. As Craig was describing, the downstream issues of these chronic infections result in dysregulation of the PNEI system, psycho-neuroendocrine immune system. I actually don't think these are separate systems. I think it's all working together in one integrated communication system, so that if we're seeing disruptions in the nervous system, we're going to see disruptions in the neuroendocrine and in immune function. You really can't separate these systems out very well. The most common manifestations of Lyme disease complex are musculoskeletal and neurological. So, I'm not going to spend a lot of time here because Craig did such a good job. Acute infection occurs with local invasion of the skin, stimulating an immune response. If it's just Lyme, it's treated early and treated adequately, the infection can be eradicated, and it often is if treated appropriately. But if there's more than one microbe present, if there are co-infections present, eradication with a short course of antibiotics, not likely. And then, again, as Craig was describing, there's dysregulation of this nervous immune endocrine functions. It's a software problem. It's not a hardware problem. We're no longer talking about bugs invading tissue. We're talking about disruption of our regulatory systems, which includes systemic inflammation generated by all these autoimmune syndromes from cross-reactive microbes or molecular mimicry, and we see immune suppression for sure. Okay, so finally getting to mental health disorders caused by these infections, huge problem. So this is a case history, 39-year-old female, RN, comes to my office. Her primary complaint all along has been anxiety and depression, which began more or less out of the blue when she was 34 years old. She lives in Western Colorado. But a good history, it determines that she has a bunch of other complaints: facial pain, headaches, palpitations, joint pains, paresthesias, night sweats, low-grade fevers, fatigue. You and I both know that if a patient comes in and says, I have severe anxiety and depression, but I also have these complaints, they're headed for a psychiatry referral, or they're simply put on a psychotropic medication. And that's exactly what happened. She was put on Lexapro and then Effexor and Pristiq, tried all three of them. She didn't tolerate them. And Zoloft helped a bit. And her husband in particular said, I think she's just nuts. Okay, basically, when we worked her up, no surprise, she had Lyme, she had Babesia. Remember, she had night sweats. There's your clue for Babesia. What else did she have? Well, it turns out her adrenals were really tired after being, sick for several years. She had methylation mutations. She had diabetes insipidus. I see this in a lot of patients. Folks, think about that. Ask someone if they pee a lot, and they'll usually say, oh, yeah, that's because I drink a lot. It's the other way around. They drink a lot because they pee a lot. So this is a pituitary problem, right? They're not secreting antidiuretic hormone. As an internist, I was taught this is a kind of an unusual endocrine condition, maybe most often associated with neurosurgery. It's not unusual. Okay, sensitivity to dairy products. Over 2 years, we basically treated her for the infections. We did our best to balance the comorbidities. And she went into total remission, was able to stop all her meds. And during the past 6 and maybe 7 years now, she's not only remained asymptomatic, but she has been fantastic. I call her up and say, would you talk to patient X, who's a new patient of mine and needs some support, needs to know they are going to get through this. Okay, so here we are, psychiatric conditions associated with Lyme disease complex, and you name it. Certainly the most common are anxiety and depression, and you might say, well, guess what? Those are really common in the general population. And then when you add irritability, anger, and ODD in kids, or even rage, that to me becomes really suspicious that there's something else going on. We see it a lot in our PANS patients, and we're not talking about PANS today. We will next time we get together. But I'm just encouraging you folks, if you see this irritability, anger issue coming up in people who otherwise have anxiety and depression for who knows what reason, think, maybe there's some autoimmune inflammation going on. What else? Well, there you go. OCD, phobias, schizoaffective disorder, bipolar, eating disorders. And this is not that uncommon in eating disorders, by the way. I had a patient with anorexia nervosa that we published, got a lot of attention. Anhedonia, alcohol, drug abuse, other addictions, dissociative episodes. That's really common too. And patients, even without asking, will often say, I sometimes feel like I'm just not there. I don't understand, like I'm standing with some friends, et cetera. This occurs a lot. Personality disorders, schizophrenia, and oh my God, suicide. So, and obviously that includes suicidal attempts, but suicide is the most common cause of death in people with Lyme disease. Okay. So when you see someone with a psychiatric illness, when should you be thinking, maybe this person has got Lyme? Okay, early onset, pre-puberty, I can tell you that Lyme, Babesia, Bartonella can all be transmitted in utero. And more often than not, the kids look okay and don't develop symptoms till somewhat later on. And I'm hesitant to say this, but sometimes those symptoms come on after vaccination. Let's say you're seeing an adult, but there's no personal or family history of a mental health disorder, and they suddenly develop anxiety syndromes. Poor paradoxical response to medications, like that case that I described. Remember, we're talking about people with neuroinflammation, and these medications don't work appropriately in some of them. New onset without psychological precipitants. This is sort of, absence of personal history, especially after geographic exposure to Lyme-demic area. But people get it in Colorado, like that dude with Lyme meningitis I just mentioned. New Mexico, which I think is probably the safest state in our union. I lived there for about 7 years. I probably saw about 5 patients who actually got it there, because even though it's a dry state, there's woods, there's forests, there are beautiful mountains. And so there are areas that can harbor ticks. So if you have the onset of psychological complaint, and there's a simultaneous onset of a somatic symptom, which often gets shunted to the side when you have a 10-minute office visit with the primary care doctor, right? that's when you should be thinking, maybe there's something going on. So here are the most common somatic symptoms. Really, it's a very long list, but fatigue, headaches, joint pains, muscle pains, neuropathic pain, neck pain, impaired cognition, sleep issues. Okay, and these patients are usually misdiagnosed. You know, patients I see in my office with Lyme disease complex, with chronic infection, oh, they've been sick for years and sometimes decades, and they've been to dozens of doctors, including Mayo Clinic. I'll get sued for that one, right? Including, you know, major university settings. And they end up with these diagnoses: chronic fatigue, fibromyalgia, some autoimmune illness with mood disorders. Mold or mycotoxin illness is more common now. It's that is being recognized. Chronic viral infections, malingerer, which is really unfortunate, you know, but often they're diagnosed as simply anxiety and depression. Okay, so dormant infections, right? A person had acute Lyme, they were treated or not treated, their immune system kept it under cover, and then it surfaced. So here are common triggers that will cause activation of these dormant infections: mold exposure, head trauma, surgery of any kind. And remember, if you're having surgery and it's general surgery, it's routine to give dexamethasone by the anesthesiologist. I said, why do you do that? And they said, well, it's good because it decreases nausea and vomiting. I'm like, geez, you ever hear of Zofran? You know, I have to tell my patients, make sure you tell them, do not give me dexamethasone. Emotional stress, we know that suppresses the immune system. Viral illness, exposure to corticosteroids or biologicals, which, as we know, are being prescribed in record numbers. Vaccines, this can really trigger autoimmune inflammation. Exposure to high altitudes. You know, Lyme is a facultative anaerobe, which is a fancy way of saying it prefers low oxygen environment. This is why HBOT, hyperbaric oxygen therapy, is recommended for some people with Lyme disease. But I can tell you that I have patients who, well, I live in Denver, and Denver, Boulder, we're both like a mile high. And I have a lot of patients say, yeah, I feel fine, but if I go to sea level, I feel great. And some of these patients will say, but if I go to Vail, you know, 8,000, 9,000 feet, I feel like crap. Okay. So I want to talk about Bartonella in particular, because I can't emphasize enough, when you see really severe neuropsych symptoms, Bartonella is almost always in play with these patients. And that includes the kids with PANS that we're not talking about yet. So huge amount of anxiety, panic attacks, depression. You can read it yourself. I mean, severe neuropsychiatric symptoms. And there was a study published by Ed Breitschwert that did describe a kid with PANS who had a Bartonella infection and responded to appropriate antibiotics. This is another study done by Ed Breitschwert. Ed Breitschwert is, I don't know, I think he is the expert in Bartonella. He's in North Carolina, hundreds of publications. This one came out, I think, at the end of 2020. And I thought it was really amazing. So they found 33 adult patients with the recent onset of neuropsychiatric symptoms. So they were adults. They didn't have a prior history of neuropsychiatric symptoms. And you can see that all of them tended to have some degree of irritability, anxiety, and depression. So there was a lot of overlap there. And they tended to have a handful of other symptoms: sleep problems, some cognitive complaints, headaches, and so on. So out of these 33, 29 had serological or PCR evidence of Bartonella. Now you're going to ask appropriately, well, what about a control group? They didn't do a control group here, but I can tell you that a control group could have 15% of people who would have antibodies to Bartonella because of, say, an old infection with cat scratch disease, right? But 29 out of 33, that's really high. Out of those 29, 24 had concurrent cutaneous lesions. And I'm going to show you these stria. And they have pictures. If you look this up, there are pictures of each one, each patient they have pictures of. And these are what's often confused with stretch marks. They're not stretch marks. And biopsies of these stria, this is not that study, it was a different study, have actually shown Bartonella. Okay, so here is a patient of mine, and you can see these horizontal lines on the back. And I want you to notice, this is obviously not an overweight person. Look at the waist. And I can also tell you, this person was seen by her family doctor who said, oh, those are just stretch marks. I'm sorry, but that's crazy. Here's a good picture of someone's arm. Here's another picture of her arm, which shows it maybe perhaps better. And here you can see all the way down the legs. Okay, what the heck are these? Well, first of all, they're in a different level of dermis and different planes than regular stretch marks, which people get from rapid weight gain, right? Bartonella has a capacity to stimulate a cytokine called VEGF, vascular endothelial growth factor, which promotes new blood vessel formation. And when that happens at this level of the dermis, you're seeing neovascularization. That's what these lines are. And they can be pink, they can be red, they can be violaceous, and they can also go pale, but you can feel them on the skin. Okay, so I would say that this slide you should print out and hang up in your office, because it's really, when should you consider Lyme disease complex in your patients who are presenting with a neuropsych complaint. So if you have patients with chronic anxiety, chronic depression, bipolar, ODD, rage, irritability symptoms, with some somatic symptoms like fatigue, impaired cognition, chronic pain, sleep problems, headaches, and neck pain in particular, or these characteristics, treatment resistance, these usual psych meds are not working, early onset, prepubertal, or sudden onset with no obvious precipitating factors, with exposure to a Lyme endemic area. You can get it in Colorado, but I can tell you the chances of getting in Colorado are a whole less likely than getting it in upstate New York. Lack of personal or family history of a mental illness, and excessive side effect sensitivity or paradoxical reactions to psychotropic meds, just like that first patient that I described. Okay, testing, unfortunately, not straightforward. Most commercial labs do inadequate, let's say it straight, lousy job testing. So the CDC has these criteria for positivity, that is for surveillance use only. And again, they state that on the website. This is only for surveillance. It is not to be used in the physician's office. But that's what happens all the time. The standard screening tool, the Lyme ELISA, has a false negativity rate as high as 57%. Imagine a pregnancy test that missed 57% of people who are pregnant. Like, how does that happen? The two-tier test for surveillance and reporting has a false negativity rate of 78%. So, we're coming right out and saying that using that two-test paradigm, you're going to miss basically 3/4 of your patients. So there are at least a handful of laboratories that are doing tick-borne testing. I can say right off the top, I have seen lousy results from Quest, from LabCorp, from Mayo, Vibrant. They're not going to be happy about that. And DNA Connections, which looks at urine PCRs. I have not seen consistent results coming out of any of these. I recommend IGeneX Laboratories. They've been doing this for a few decades now. It's all they do. And I think that they do a good job. If you're screening for just Lyme, which I think is a good way to start, then sure, you can test at your LabCorp or Quest and order the Lyme ELISA and order a Western blot. But if it's negative, don't stop there. I can't tell you how many patients I've seen with totally negative tests in those labs, but have significantly positive tests at IGeneX. So if I'm doing a screening test, I'll start with immunoblot, IgM, and IgG, and I even gave you the code, the 325 and 335 are those two tests, and it does cost $450. And then you want to really learn a lot about this or develop a relationship with a Lyme literate doc who can help you in interpreting the results, because it's not straightforward. And I need to mention Babesia and Bartonella, even at IGeneX and some other specialty labs like Galaxy, the testing for these is better, but it's still not great. I mean, maybe it's up to 60 to 70% sensitivity, but I'm still diagnosing an awful lot of these people clinically. So let's say you do a Lyme test. This, I think, is in Massachusetts. Don't trust a negative test. So let's come back to the Lyme immunoblot test. So basically, we're looking at antibodies to proteins in the Lyme spirochete. This is really, really important. I'm going to come back and say it again. IgM positivity is not only recent infection, it can also be persistent infection, perhaps because the outer surface proteins on the spirochetes are changing and the immune system recognizes these infections as more recent. At any rate, the vast majority of my patients who come to me who've been sick for years and years, not treated, have disproportionate IgM versus IgG positivity. And when they see the infectious disease doctor, if they can even get in the door, the doc will say, well, you've been sick for years. This is clearly a false positive. It's upsetting. Okay. IgG starts to rise at 4 weeks after infection, but may not if the patient is untreated. We might just see the persistent IgM. In the immunoblot, a 31 band is slam dunk, absolutely slam dunk for Lyme. But there are other bands that are almost slam dunk, particularly the 23, 25, 34, 39, and 83, 93. So if I see positive bands in any of these, I'm going to be very, very suspicious. The most sensitive band is 41. That's an antibody to a flagellar protein, but it's not specific. They're non-pathogenic Borrelia that can generate that. Often IGeneX will print out indeterminate. Indeterminate positives mean there was reactivity. These are done by highly trained technicians, and they want you to know they saw something there. It was not as strong as the positive control. But if you look, you'll see that usually those indeterminate positives are in these Lyme-specific bands. And I generally interpret these as positives. So again, persistent IgM, which is really often considered a false positive. I've seen this several times. That occurs in chronic untreated infections. The sicker the patient, the more the immune system is suppressed. And guess what? You're going to see less antibodies showing up. The not as sick patients more likely to have positive tests. And the patient will say, oh my God, I have so many antibodies on this immunoblot. Does that mean I'm really sick? And the answer is no. Actually, it means your immune system is really working well. So sum it up. First, the truth is ridiculed. Then it meets outrage. Then it is said to have been obvious all along. By Schopenhauer, I mean, clearly this has to do with what we're learning about what Craig was talking about. There's huge implications here in terms of inflammation and mental health disorders that I've been talking about, tick-borne microbes stimulating this. But stress itself actually causes neuroinflammation. Post-traumatic stress disorder, huge amounts of neuroinflammation, and then this neuroinflammation in turn can generate the anxiety and depression, etc. And this is my quote: if you look, you will find it. Sounds like If you build it, they will come. But I'm telling you, if you start looking for these infections, you're going to find it. And there's my book. It goes into all of this in a lot more detail. And thank you very much for your for being here and listening. Thank you.
Thank you so much, Dr. Kinderlehrer. That was absolutely fascinating. I have a couple of questions, but at this time, we would just like to open up the webinar for our participants to see what questions they might have of you. That's okay. Craig, you are still muted. I wanted to let you know that in case you have a question that you'd like to ask.
Thank you, Amy.
We have one question. Dr. Kinderlehrer, how did you treat the diabetes insipidus in the 34-year-old patient?
Aha. That's very nice. So first of all, I want to mention that when I see diabetes insipidus, I'm often also looking for toxicity syndromes that might be hampering pituitary function. And the most common one is mold toxins. So if I see diabetes insipidus, the next thing I do is I'm going to start looking for mold toxins. There are a few pituitary glandular products. I happen to use one from Standard Process called pituitrophin that I would say have worked in at least 50% of my patients. And what are they doing? I don't know what they're doing, but I can tell you that I have patients going from getting up 3 to 5 times a night to getting up only 1 to 2 times a night to pee. And people saying, I'm not thirsty all the time. Instead of drinking 3-4 liters of water a day, I'm drinking 1 or 2 liters of water a day. And I have patients. I had a patient just yesterday. We tested her urine volume, and it was 12 liters a day. And we put her on the pituitrophin. She's down to 7 liters. Not great, but a whole lot better than 12 liters. She's not peeing all day. So if I can get a good response from pituitrophin, which on paper, it's a glandular, and they're called protomorphogens, are supposed to somehow kick the pituitary gland into working better. Is that really what's happening? I have no idea. Maybe there's actually some vasopressin or antidiuretic hormone in it. I don't know. But I can tell you I've gotten good response from that, as well as some other pituitary extracts. And that's where I'd like to go. If I can get the pituitary to do its own work, that's what I'd like to do. But there is a prescription item, desmopressin, that can be prescribed either nasally or orally. And basically, you're substituting what the pituitary gland is not making. And unfortunately, over 25% of my patients don't tolerate it at all. They take one tiny dose and they get a headache that keeps them up all night. I don't know why it's just not treated that well. It can also be given sub-Q, by the way. But so if they're not responding to the glandular, that's what I'll try, but with a lot of warnings, starting at very low dose. I'll try a prescription for desmopressin. Otherwise, by the way, there are things that you can do. Giving people a lot of electrolytes will help. And also, at least on paper, licorice can help in terms of having some effect on some renal hormones. But really pushing a lot of electrolytes often makes a difference.
By licorice, do you mean licorice root?
Licorice root, thank you.
Okay. Dr. Kerr has a question asking about any thoughts you might have about underlying genetic or gut microbiome related vulnerabilities that predispose to or perpetuate chronic tick-borne illness, and which genes and gut biomarkers may help with us understanding this predisposition.
Craig talked a bit about genetic predispositions, and I think that there's no question that there are HLA types that are more prone to autoimmune illness, and it's a definite risk factor for people becoming more ill or more chronically ill when exposed to tick-borne microbes and other microbes as well. In general, we're seeing a lot more autoimmune illness than we used to, and I think that's probably due to a number of factors, but remember, we're talking about epigenetics as well. And so we're seeing this combination of do you know that 15% of the world's population has either have Lyme or had Lyme? This study came out fairly recently, and a study in Britain where, as you know, there's a National Health Service. 10% of 20 million people had an autoimmune illness. So we're seeing lots of problems there. And, and you can look at the HLA typing and the B27, DR2, DR4, et cetera. I don't know how it's going to change treatment. I think the microbiome question is really interesting. And I think there's probably some really important stuff there, but I have no idea what markers there are there that are going to that we can measure that are going to affect treatment.
Yeah, I might add just a little bit on those thoughts that the genetic markers certainly predisposition to various types of HLA and different types of what we'll call self, non-self dysregulatory genetics. But the other is, as Dr. Kinderlehrer mentioned, the epigenetic component, which is the methylation patterns, which are affected by stress, by food, by different types of things. And I think that'll come into play. We do know that there is work identifying different types of potentially pathogenic or different type of commensal bacteria. And you see that in cases such as autism, where there's a narrower spectrum versus a diverse spectrum and a different types of species associated with them, whether that's causal or if that's an effect. But there is a diversity restriction in many of these types. And autism has been, or autism spectrum disorder is some portion of that, anywhere from maybe 50 to 70%, has some immune dysregulation on top of it. So whether it's comorbid or if it's a part of it. So there is a lot that I think that will be unfolding here because none of these organ systems are operating independently.
Another question Dr. Jeffrey asks, I had a patient this week who had SOT therapy for Lyme, supportive oligonucleotide therapy, that she was unfamiliar with, and is asking if you know anything about SOT therapy for Lyme.
Wow. The answer is I know only enough to be making mistakes if I try to talk about it. It's really one of the newer, it's been available for several years now. I don't pretend to understand it. I have seen mixed results from it, but I sadly really cannot talk about it in any depth that makes sense because I don't understand it.
Yeah, I might just agree with that. The technology itself is very similar to what other therapeutics are looking at, and that is basically using a complementary sequence of some type of target where you're actually shutting off the expression of those sequences. So that's the underlying biological mechanism. And there are other therapies, not necessarily this one that I'm familiar about either. It's the selection of what sequences, is that being expressed? And then are you able to get it into a place where the organism will actually uptake it into themselves? So I would say that probably someone who is using that might have a better understanding of the effectiveness of it. And probably I'd say there's differences in the types of sequences or the different genetic sequence that is being used, or the stage in which the organism is at. As Dr. Kinderlehrer described, this is an organism that has multiple different life cycles, and so therefore they're expressing different proteins.
And one final question, Dr. Kinderlehrer. In patients whose lab results reveal only a a positive or a reactive band 41. Do you recommend further testing in those cases? Is that a clue for additional testing?
It's a really good question because it comes up. And I would say that the indication for more testing really has to do with the clinical presentation. If a person says, well, I think maybe I had Lyme and now I have a sore knee, but they're a runner, have other reasons to have whatever their complaint is, and that's all they had, I probably wouldn't pursue it. But if, let's say someone's got some chronic neurological and musculoskeletal complaints, then I might say, well, you could have Borrelia miyamotoi. That's not going to come up on a standard Lyme test. You could have co-infections. You could have, if you're really sick, you could have immune suppression, and then you're not going to see antibodies. So it really depends on the patient's clinical presentation, whether I'm going to pursue more testing. Now, there are also, there's protocols in which if we're really suspicious and haven't been able to document it, we actually give antibiotics for a month. And in the process of treating these infections, basically causing some destruction of these microbes, it can generate more antibody response and then repeat the immunoblot. And I've seen that produce positive results.
Thank you. I want to thank you who participated in our webinar. We will be sending out a recording in 2 or 3 days to all who have registered and all who have attended. We thank you very much. We hope you'll attend our webinars in the future. Dr. Kinderlehrer, our sincere thanks for your time, the preparation, your insights, your knowledge. I know everybody who participated is very grateful to learn from you. I'd like to add my thanks to that as well. And Dr. Shimasaki, thank you so much for moderating and allowing this webinar to take place. And I look forward to our next one. Do you have any final words?
Thank you, Amy. I'm going to add one thing here. We're going to call this webinar 1. There will be a second webinar that Dr. Kinderlehrer will share with us. He did a superb job of addressing the issue with tick-borne diseases and the significance of these. The second one will be related to more treatment. We'll talk about pandas and pans and some of these other things. So I want to add my thanks both to you, Amy, and to Dr. Kinderlehrer for informing us so eloquently about how severe this problem is. And we'll look forward to hearing more about how you solve this problem with treatment.
Right.
Thank you.
Thank you all. Thank you all very much, and until we meet again.